Hello there, I am presenting my concept map about Parkinson's disease. So, what's Parkinson's? Parkinson's is a neurological disease where a portion of the brain called the substantia nigra stops producing enough dopamine. So, what dopamine does is that it controls smooth and coordinated movements. And it works together with another neurotransmitter called acetylcholine. And what that does is that stimulates muscle activity. So when they work together, they keep the movements balanced. So what might end up happening is that in Parkinson's, if we lose a lot of dopamine, acetylcholine becomes overactive. And this imbalance creates what's known as Parkinson's disease. All right, so moving to assessment boxes, we focus heavily on neurological function, which is why we assess for gait, posture, balance, coordination, deep tendon reflexes, the presence of resting tremors, and muscle rigidity. Why we do this is because remember, Parkinson's is a result of dopamine deficit and unchecked acetylcholine activity. And as for acetylcholine activity, it affects the basal ganglia and extrapyramidal system. And so these areas are responsible for regulating posture, muscle tone, and voluntary movements. This is kind of why we assess these functions because this serves as a baseline of severity of the disease, which I'll talk about in the next box, signs and symptoms. All right, so next we check orthostatic vital signs. We do this because we need to monitor for posterior hypertension, and this is mostly caused by anti-Parkinson's medications, usually by amantadine, dopamine agonists, COMT inhibitors, and what this does is it causes dizziness and cynoscope, which is also means fainting, and this will definitely increase the patient's risk for falls. So we check cognitive and psychological neural assessments as well. So the thing is, Parkinson's is actually a progressive disease. It just gets worse, unfortunately. So 40% of patients actually experience psychosis and hallucinations, and these patients are more likely to uh, be susceptible to depression, emotional fluctuations, and social withdrawals, just because of the nature of this disease. That's so unfortunate. And some medications can actually have an adverse effect on it as well. So, for example, like anticholinergics, they can cause confusion, memory impairment, depression, anxiety. So that's something to watch out for. So next, before anything else, we need to check the baseline before starting any drug therapy. So we have to check for renal functions, which include BON and creatinine, and hepatic functions like ALT and alkaline phosphatase. So for many drugs, right, these anti-Parkinson's drugs rely heavily on kidney and liver for clearance and metabolism. So that's why we had to check these four. So these four, if any of these values are abnormal, the prescriber could decrease the dosage, and that's just to prevent toxicity. And other drugs like COMT inhibitors, they will carry black box warnings, and that's going to indicate severe liver failure. So that's why we try to make baseline so we can always adjust. All right. So we're looking for the next box, which is signs and symptoms. Specifically for Parkinson's, there are four cardinal signs, and it uses an acronym called TRAP. It stands for tremor, rigidity, akinesia or bradykinesia, and posterior instability. Bradykinesia just means slowness of movement. So, just to be a little bit more in depth about that, it's very direct. It's a very direct physical manifestation, and this usually occurs when 80% of dopamine that's stored in the substantia nigra are depleted. And this causes unchecked acetylcholine production. And this is an overstimulation that causes resting tremors, cogwheel rigidity, and of course bradykinesia, also known as slowness of movement. Next, we have secondary physical symptoms. Usually these are extensions of bradykinesia and rigidity. And this affects certain muscle groups like we're talking about head, neck, and face, and this is kind of going to cause a mask-like facial expression and impairs muscle coordination, like, you know, the way you talk, the way you chew, and the way you swallow. And next thing you know, we're going to talk about constipation. So there are two underlying factors about this. Neurological stuff, neurological disease, of course, it slows down the normal gastrointestinal peristalsis. And, medications like antichlorogenics, this is going to cause the GI motility to decrease. Psychologically, of course, we know that Parkinson's is progressive and it's chronic. So they're going to experience depression, and they're going to have to deal with physical decline, appearance changes, and the loss of independence. Very unfortunate. And then later on, as the disease progresses, 40% of patients are going to experience psychosis, hallucinations, as a result of brain degeneration. And this can also be caused by, you know, other medications like COMT inhibitors, amantadine, and things like that. So next we check for abnormal labs and diagnostics. So there's not really any specific blood tests, imaging scans, or laboratory markers to confirm Parkinson's. So instead, clinicians, what they do is they check for family history. And this is because like 20% of patients with Parkinson's, they usually have a genetic link to it. And they're also checking, obviously physical exam findings like what I said earlier, the TRAP acronym. Next, we check for orthostatic blood pressure, right? So anything like any significant drop of blood pressure, whether it's like lying down, sitting, or standing, this is due to Parkinson's being progressive neurological disease, and this impairs autonomic blood pressure regulation. Or, let's say you're using a primary anti-Parkinson's medication that lists posterior hypertension. It's going to be like an adverse effect. Next, we're checking for elevated renal labs like BUN and creatinine. So what these two do is they indicate how well the kidneys are filtering the waste. If any of these are high, this is due to like maybe an underlying renal impairment or any drug-induced urinary retention from antichlorogenic side effects. And since, because these drugs are cleared through the kidneys, we have to track these labs because we want to prevent drug accumulation and toxicity. We're also checking for elevated hepatic labs like for, ALT and alkaline phosphatase. And this is because these two, they monitor liver function, So because the liver is metabolizing, medicines, it's important to track any elevated ones because let's say that there's a medication like tolcapone, so it's gonna have a strict black box, right? And it's gonna indicate severe liver failure. So any elevated levels of ALT and alkaline phosphatase, they're gonna basically discontinue using the drug. All right, so the next is medications. So the thing is about Parkinson's, there's no cure. Drug therapy, there's no cure, unfortunately, for this disease. So what the drug does is that it helps manage symptoms and improve quality of life. The first of these drugs is known as dopamine replacement drugs, such as corbitopau and levodopa. Levodopa crosses the brain and converts directly into dopamine. But the thing is that before reaching the brain, a lot of it is broken down. So that's why it combines with carbidopa to prevent any peripheral breakdown. This allows the levodopa to reach the brain, reducing any side effects like nausea and permitting lower doses. The next is MAO-B inhibitors. So MAO-B is an enzyme responsible for breaking down dopamine in the brain. So what the inhibitor does is it blocks this enzyme, allowing the medication to remain active longer and improving dopaminergic stimulation. COMT inhibitors, they work a similar way. I cannot pronounce this enzyme, so I'm just going to call it COMT. So what this does is this prevents the breakdown of levodopa, levodopa, it prolongs its effects, reducing a phenomenon called wearing off, and extending the amount of time patients experience a good symptom control, also known as an on time. Another class is dopamine agonists. So what this does is it stimulates dopamine receptors. It's usually used for like initial therapy alongside levodopa to delay any like higher doses and reduce long-term motor complications. Next is dopamine modulators, and they kind of work a little differently. They promote the release of stored dopamine from remaining healthy nerve cells while also blocking dopamine reuptake. And this allows dopamine to stay active longer. So I'm gonna butcher the name here, amantadine. What this does, it has mild anticholinergic effects, making it extremely useful for controlling tremors, rigidity, and levodopa-inducing dyskinesis. I believe that's how I said it. And finally, there's anticholinergic medications. What this does is reduce excessive activity of acetylcholine by blocking cholinergic receptors. These drugs are highly effective of improving tremors, muscle rigidity, but the only problem is there's a little effect on bradykinesia, also known as slow movement. Alright, next we're going to look for our first nursing diagnosis, which is wrist or falls. So, for what I put for my statement was wrist or falls related to bradykinesia, postural instability, and drug-related orthostatic hypotension as evidenced by unsteadiness, shuffling gait, and reported dizziness while standing. So we gotta remember bradykinesia and postural instability. This makes it hard to catch any balances. Also, any anti-Parkinson's drugs cause any orthostatic hypotension, which induces dizziness, and cinoscope, also known as like loss of consciousness, unsteadiness, and shuffling gait physically confirm the risk. So what are the solutions? All right, so teaching the patient to train to position slowly. So we want the cardiovascular system to compensate for blood pressure shifts to prevent orthostatic dizziness. We also want to clear any fall hazards in the environment, whether it's in the room or home. And then we want to engage in physical therapy to promote ambulation. We want to maintain mobility, muscle strength. We want to make their life easier without any reliance, just for independence. So the smart outcome would be the patient will have a zero fall incidence during the care period and demonstrate the slow position change technique corrected by the end of today's teaching session. All right, for my second diagnosis, I chose constipation. So the statement was constipation related to decreased gastrointestinal motility secondary to Parkinson's disease and anticholinergic or dopaminergic medication effects, as evidenced by patient reporting infrequent heart stools and abdominal distension. So we've got to remember, Parkinson's is a degenerative disease. It slows down smooth muscle peristalsis, and any medications like anticholinergic, what they does is it suppresses GI motility, and this obviously leads to chronic constipation, infrequent heart stools, and abdominal bloating. So what are some solutions, right? So we have to encourage fluid, right? Getting enough fluid is essential to solving stools and prevent fiber from causing any blockage, right? We want to increase dietary fibers, and this by adding, bulk or mass to the stool. This stimulates natural peristalsis, and it's just going to basically help with gut motility, right? We're also going to promote ambulation. So physical movement in general stimulates the abdominal wall and intestinal muscles to prevent stagnation. And the smart outcome that I created was the patient will report a soft, pain-free bowel movement at least every 1 to 2 days with no straining within 1 week of starting the fluid, fiber, and activity plan. Hello, so we're going to do my next clinical concept, which is acute kidney injury, also known as AKI. So it's characterized by abrupt deterioration of kidney function, and to evaluate this, we characterize this by 3 main areas. Pre-renal, which is caused by decreased renal perfusion to the kidneys. This reflects issues before any kidney issues, where poor blood flow or low systemic blood pressure starves the nephron of the oxygen and blood that need to function properly. There's intrinsic renal, which is caused by direct structural damage within the kidney tissues and can lead to acute tubular necrosis. This involves acute cellular damage to the renal parenchyma or tubules themselves, often caused by toxins, or prolonged pre-renal injury. Post-renal, this happens when urine flow is physically blocked downstream, such as enlarged prostate, stones, or tumors, causing a back pressure that impairs renal function. So, what are the signs and symptoms? So, for urine change, when kidneys fail or backflow is blocked, urine production drops drastically, meaning the body cannot effectively clear liquid waste. Fluid electrolyte imbalances, it can manifest as hypervolemia, hypovolemia, peripheral edema, and rapid weight gain. This is caused because kidneys cannot regulate fluid volume or solute concentrations. The fluid builds up in the tissues, which is kind of the reason why you have edema or weight gain, and this shift can be unpredictable. So for cardiovascular, it's important to note that S3 heart sounds are heard, murmurs are heard, pericardial friction rub, and ECG dysrhythmias. This is caused because fluid overload strains the heart muscle, which is why it creates an S3 sound. It's dangerous electrolyte shifts like potassium imbalances disrupts the heart's electrical conduction system, and this causes dysrhythmias. Respiratory, fluid overload can cause crackles, wheezes, or decreased breath sounds. Unfiltered fluid backs up into the pulmonary circulation and into the interstitial spaces of the lungs, impairing gas exchange and producing abnormal breath sounds. Neurological, uremic toxins and electrolyte shifts can result in confusion, lethargy, and altered mental status. This is because when the kidneys fail to filter urea or creatinine, these waste products cross the blood-brain barrier and cause uremic encephalopathy. I can't pronounce it, so I apologize. But anyway, it dulls the cognitive function. So we're checking for assessments and physical examinations. All right. So the core monitoring, we check for vital signs, right? We're checking for hypertension, tachycardia, fever, and respiratory changes indicating volume depletion. So why we do this is we need to provide an immediate snapshot of systemic stress, and this helps us catch any shock states or severe fluid overload early on, right? We're checking for urine assessment, right? We measure precisely oliguria and anuria. So, hourly or daily urine tracking, it's usually the gold standard for evaluating real-time renal filtration capabilities, and then we check for physical examinations, right? So we do a thorough cardiovascular examination, we do auscultating the lungs for FHC sounds, inspecting peripheral edema, checking skin integrity, and assessing musculoskeletal systems for muscle tenderness. This is more like a hands-on exam. This catches any physical manifestations of any fluid retention, electrolyte disturbances, anything that doesn't escalate to any acute emergencies. Next, we check for abnormal labs and diagnostics. So we check for serum creatinine and BUN, and those are usually elevated. Urine sodium, low urine sodium points to pre-renal AKI, and high urine sodium indicates interrenal damage. Electrolyte panels reveals hyperkalemia, hyponatremia, and hyperphatismia. I don't know if I'm pronouncing that right. Anyway, and any EBGs, it typically shows metabolic acidosis. So, creatinine and BUN, what that does is when it builds up, filtration stops. What urine sodium tells us is that the kidney is desperately trying to hold on to the sodium, or leaking it because the tubules are damaged, which interrenal, right? Metabolic acidosis, this occurs because the kidneys fail to excrete any hydrogen ions and reabsorb bicarbonate, right? Next, we're checking for diagnostic imaging tests. Urinalysis reveals different cellular findings, while renal ultrasound, Doppler ultrasounds, and abdominal pelvic CT scans and renal biopsies, what they do is they provide structural insights. Imaging rules out physical blockages, like stones, tumors, and this evaluates blood flow and kidney structure, right? Next, we check for medications, right? So it's very important to be very careful with medications, right? Diuretics like loop diuretics like furosemide, I can pronounce that. Bumetanide, I apologize if I mispronounce that. So alongside any osmotic diuretics like mannitol are used to manage fluid volume overload. But remember, these drugs force the kidneys to excrete excess water and sodium. We don't want any fluid burdens on the heart or lungs. And then hyperkalemia management, right? So we need to protect the heart from dangerous potassium levels, which is why we would use IV glucose and insulin, IV 10%, calcium gluconate, sodium pyrene sulfonate. God, I'm butchering a lot of these. Biturmir and sodium cyclonium cyclosilicate. So remember, high potassium is life-threatening due to cardiac arrest risk, right? Insulin glucose, what it does is drives potassium back inside the cells temporarily. Calcium, what it does is protects the heart muscle membrane stability, and it binds actively to remove potassium from the body. All right, so what do, right? There's some diagnosis, right? So one, I say excess fluid volume. Now, remember, I chose this because the patient is demonstrating a failure to excrete water and filter waste properly. And so this can be as evidenced by peripheral edema, crackles during auscultation, and rapid weight gain. So what we need to do for interventions, right, is we monitor intake and output alongside daily weight, administer IV loop diuretics, and prepare the patient for dialysis if volume overload becomes refractory. My SMART outcome that I picked was that the patient will achieve adequate fluid balance, clear lung sounds, and visibly reduce edema within 48 hours. For my second, I chose risk for electrical imbalance. So this is due to, declining glomerular filtration generally repairs the renal excretion of potassium, placing the patient at high risk for fatal cardiac complications. This is directly tied to reduced renal excretion of potassium due to reduced kidney functions. So what are the interventions, right? So I chose monitoring electrolyte imbalances, paying close attention to severe hyperkalemia that's above, 6.5, 6.5, and I will educate the patient on dietary potassium restrictions and administering irregular insulin with D50 IV to shift potassium out of circulation. And so the SMART outcome that I made was patient's serum potassium levels will remain within normal limits with no ECG changes or hyperkalemia within 24 hours.